Hello, everyone. Welcome. I can see that lots of people are slowly logging in, which is very good to hear and see, rather. Okay, so we'll just wait a minute where everyone is slowly, well, actually quite rapidly logging in. So give it 30 seconds. So while everybody's logging, let's just do a bit of small talk. Okay, so welcome to this radiology seminars monthly evening webinar. Thank you very much. As always, we've got excellent stuff this month. Last month was very, very popular. It was the bone tumor mimics on imaging, particularly on plain film, and it was very, very popular. It was done by Dr. Ramraj from the Royal National Orthopaedic Hospital at Stanmore. And so continuing from a similar theme on trauma radiographs, musculoskeletal theme, Dr. Imran Lasker, who's a consultant radiologist at Basildon, who will be taking you through very much a case-based approach to some of the commonly missed or subtle radiographs in trauma. And this is not really just for radiologists, it's anybody who reviews trauma x-rays. So you might be an A&E, a doctor, or a reporting radiographer, or somebody who just sees patients with trauma. It doesn't necessarily have to be some major trauma. There's mainly a lot of subtle fractures that people don't necessarily appreciate. So one thing is, as you guys know, that radiology seminars hold evening webinars once a month. We've got an excellent one happening next month. It's going to be on abdominal radiographs. Okay, so with that, I think we've got lots of people signed in. As always, this session is very, very popular. I'll hand over to Dr. Lasker, who will take you through the next session of this. Over to you.
So I think you have to make me host. No, do you want to share? I'll do that. Okay, share. And then, so just, I'm going to just switch the camera. Oh, unable to start video. You stopped the video, have you?
We can also, I can see a screen, so don't worry.
Okay. That's fine.
Just not showing your face.
Okay, yeah, I've got the other camera on, but that's fine. So basically, hi everyone, my name is Dr. Lasker. I'm a consultant radiologist. And what I'm going to do actually is just put something onto the, oh yeah, we can start the video then. No, can't do. I'm going to just put something onto the chat. Where's the chat function again? Q&A, no. Oh, here we go, chat. So I'm going to put this website address onto the chat. And so basically, I would like everyone, if you do want to try and sort of keep up with what I'm doing, then you'll be able to kind of go through these cases with me live on the spot. Hopefully that works. And we'll be able to go through a few cases. So we're going to go through some really interesting cases in no particular order, but they go from sort of slightly easier to kind of getting progressively harder. And I'm going to go through how to actually look at, how to use a system to try and figure out what you're looking at. And so, Etcham, is there any way to switch the camera on, by the way? The video. So it doesn't seem to be working on the camera side of things, but hopefully everyone can see what I'm looking at. So this is a frontal chest radiograph, and I'm just going to give you hopefully a really good way to try and assess these x-rays when you are on the A&E or on the wards and the rest of it. So generally speaking, you just want to go through back to basics, but if you haven't seen anything grossly abnormal on the first run, when you've seen it, you don't see anything just that kind of jumping at you, you've got to go to your check areas. And the check areas I always use are the lung apices. I have a good look at lung apices, just to try and see if there's any evidence of a pneumothorax. And I'll show you an evidence of a pneumothorax in a bit, but I'm not going to show you a normal x-ray whatsoever during this entire talk. So if you think you see an abnormality, what I'd like you to do is just try and put it up in the chat. And so I can just see that, people are trying to have a look at it as well at the same time, if possible. So once you've had a look at the lung apices, just have a look down at the mediastinum as well. So this mediastinum is actually this area over here. So this mediastinum is this entire middle block over here where, the heart is, the aorta and the rest of it. So back in the day, they didn't really understand that there was something called a mediastinum. Oh, they didn't know that it was made up of an aorta, an SVC, the heart. They thought it was just literally one solid structure. And so They just gave it one particular name, the mediastinum, but the mediastinum is actually made up of lots of stuff. And as you kind of get good at looking at X-rays, you start to realize that it has a very, very almost definitive shape to it. So if you start to see a little bump around here or here, that's when you start to worry. So on this X-ray, we've had a look at the apices. We haven't seen anything wrong. We've had a look at the mediastinum, haven't seen anything wrong. So now we've got to start looking at the rest of the check areas. Check areas would also be the costophrenic angles that are sitting over here, and they all look normal. And then under the hemidiaphragms as well, just to make sure there's no air underneath the hemidiaphragm. So, average, generally speaking, if you're in a rush, you might think, okay, well, I'm done now. That chest X-ray looks okay. But when you start to sort of mess around with the contrast a bit, one of the other very important check areas will hopefully become apparent. And yes, someone's got it already. There is something sitting behind the heart. For those of you that haven't seen it, there is something that is sitting over there. So there's a retrocardial mass, and that is something that needs to be investigated. But, that needs to be investigated, and that needs to be taken quite seriously. And this is the thing, we often forget that, this is a 3D, we're looking at a 2D picture of a 3D person. So if you have something sitting in front of the heart or behind the heart, it may be obscured by the heart border. And that's something that's really, really important to remember whenever you're looking at X-rays, whenever you're looking at these emergency films. And so the take-home point for this particular X-ray is to have a really good check system. If you don't have a check system, use mine. It's looking at the lung apices, look at the mediastinum, look at the costophrenic angles, and look under the hemidiaphragms as well, and obviously behind the heart for any nasty surprises that can happen. So good, well done. Someone did get that, that's really good. So we'll go to case number 2. So like someone's done already, please feel free to, get stuck in, have a look, tell me what you think. And don't worry, if you haven't seen it, it's not a problem. We're on case number 1 was a retrocardiac mass, and I just quickly pointed out for someone, just quickly, so sitting just behind the heart over here. So you can have a look at that later if you want to. So let's go to case number 2. Some of us had a bit of a head start with case number 2. So case number 2, I'm going to make it like we do with the radiology exams. They don't actually give you a history. So you literally get given an X-ray and you have no idea what you're looking at. So, or why they've even done it in the first place. So some of you may have seen this problem, some of you may not, and don't worry if you haven't. I'm going to work through it. So let's say, for example, you haven't seen the problem. You haven't seen any abnormalities from the outset. You think, okay, this looks like a normal plain film. Well, let's use our check areas. Let's use what we usually would use. Let's have a look at the lung apices. They look all clear. There's no evidence of any pneumothorax. So apical pneumothorax is things that people often miss. They really do miss apical pneumothoraces. And I will have a good case of it coming up. But if you ever think you've seen a pneumothorax, just try and point out where the lines are going. If you think you've seen pneumothorax, just follow the line, and usually you'll find it's not pneumothorax, it's actually the border of the ribs, or it's actually the border of the scapula that's making you think that there could be a pneumothorax there. Again, we'll look at the mediastinum. We're not going to get caught out by behind the heart like we did last time. Maybe some of you didn't. And then also we want to check the costophrenic angles, okay? So costophrenic angles look okay. Under the hemidiaphragms also looks okay. So we're a bit of a conundrum, right? I've told you that those are the check areas, but there's actually one more check area that I didn't want to give straight away because, I didn't want to give the answer to this next particular case. And it looks like some people are very switched on today. So yes, you look at the bones, 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 right? And so when let's say, if you're using your standard way, so lung apices, et cetera, you want to look at the bones and just follow. You want to make sure you see the posterior aspects of the ribs and the anterior aspects of the ribs as well. And quite rightly, someone has spotted that there is this shadowing that is sitting over here. Now, if you haven't seen that, don't worry. Just try and think about symmetry, right? Think about symmetry. We're not entirely symmetrical in reality, but you want to just make sure that, on this side looks the same as this side looks the same as this side. And in this particular occasion, what you may have noticed is that there is increased opacity located within the right lower lung zone. Now, if you didn't see that increased opacity, you may, if you used your normal check way, the check things that I'm trying to give you is look at the posterior rib, look at the posterior rib. It's not there, it's not there. So this is actually not a breast mass, which someone has said, and fair enough, you can say that. But you have to think about where we are in the body, and we can see that the posterior aspect of the rib is just not there. And actually, this turned out to be a lung lesion that was eroding the posterior aspect of the ribs. So yes, I can see why you thought it could be a breast mass. And, fair enough. I think that's not a bad shout as well. But, once you've seen it, don't just stop. I think sometimes we see an abnormality, but we don't think of the next thing. We think, okay, we're done with that film, let's move on. But actually, as radiologists or health professionals, we should be thinking about the next step, the next step, and the next step. And, we should have a check system. So what I'm saying is, the apices, the mediastinum, et cetera, are very, very useful, because even when you've seen the abnormality that you think you've seen, try and look for the next thing, and use a check areas to hopefully spot the thing that could really give you what's really going on this particular patient. And this particular patient, it's a destructive bone lesion that is resulting in this destruction in the in the posterior rib over there. Great, good. So yeah, we've got some really switched on people today. So now let's go to case number 3. Now, case number 3, maybe someone sees it quite quickly. The trained eye might see it, okay? But right, let's just say we haven't seen anything abnormal. Let's use my check things, right? Number 1, the check thing was the lung apices, yeah? The next thing was the mediastinum, the costophrenic angles behind the heart, under the hemidiaphragms, and then yes, we do check the bones. So let's go for the first bit. So lung apices, let's have a look at that lung apex on the right side, and then we look at the lung apex on the left side. Now, I don't know if everyone can see that, and hopefully if you can't see it on here, then go ahead and go to the website and have a look, and you hopefully be able to see that there is a linear line sitting just over here. Now, yes, exactly. People are writing already, this must be pneumothorax, but I want you to be careful before you say it's definitely pneumothorax. I need you to think about the next thing and the next thing. So if this is a pneumothorax, we should not have the line to veer off anywhere else, but more importantly, we shouldn't have any lung markings beyond the line that we think is a pneumothorax. Now, I know people throw around, lung markings, but what does that actually mean? So if you look a bit closer, you can actually see the sort of streaky bits within the lung. Those are the airways and the rest of it. That's what gives you the lung parenchymal appearances. But when you go beyond this line over here, you can't see those lung appearances at all. Now, a consultant I used to train with was very good at it. She told me that if you're ever unsure, what you do is you draw a box and only concentrate on that box, and then go to the other side and concentrate on that box and see if there's a spot, the different style situation, right? And actually, when you see on the other side, you can see that there is linear opacities that are kind of going all the way to the edge, but there's not much in the way of linear opacities going off. Oh, it's not even my phone, it's my wife's. She left it. And my apologies. I have no idea how to switch an iPhone off. I'm an Android person. Right, I think that's done. Apologies. So yeah, you can hopefully see that there is some, the lung markings don't go all the way to the very, very edge. Right, so do we stop there? No, we're radiologists. We've got to think about what could have caused the problem in the first place. So the problem in the first place could have been caused by a rib fracture. So you just got to make sure that you've had a good look around to try and see whether there's any rib fractures or anything like that, because oftentimes you won't get very much in the clinical history beyond the fact that they're breathless and they got chest pain. In this particular case, we don't have a rib fracture, but secondary findings are here with regards to the pneumothorax. And what I mean by that is if you've got a pneumothorax, you're also going to have a loss of hemithorax volume. And can you see there's a bit of tenting of the hemidiaphragm? Look at the diaphragm over here and look at the diaphragm on the other side. So there's tenting of the hemidiaphragm, which basically means there's loss of lung volume on the left side, which further tries to convince you that there is something going on the left side of the hemithorax, which is in this case a pneumothorax. So that's a really great case and something that should come to you once you use those sort of check areas. Now, don't worry, I'm not going to just labor on chest x-rays the whole time. I'm going to go kind of straight to the point on this one. Hopefully someone has seen it. But again, lung apices are all okay. But again, we're looking at something that's behind the heart. Behind the heart, we can see that there is this opacity that is sitting here, given this what looks like a sail. Exactly right. So it's a left lower lobe collapse and looks like a sail. For those of you who are into sailing, then this is what that apparently looks like a boat. I'm not into sailing, but this is a boat as well. So you can see that this is a left lower lobe collapse. And actually on this one, you don't have much in the way, you don't have tenting of the hemidiaphragms, right? But you do have some slight elevation of that hilar as well to say that there is some loss of volume on that side. So I'll kind of push through that chest x-ray because I do have some really great cases coming up that I want to go through with you guys. Obviously, if you have any questions, I'm going to hang about afterwards, you know, so if you do want to ask me anything, then go for it. Now, facial x-rays can be really, really daunting. And I find that in the beginning anyway, people are really, really put off by all this cauliflower looking stuff that's sitting all over here, all these streaks all over here and all this stuff, okay? Do not worry about that stuff. Those are the normal sinuses. Those are sinuses that are part of the normal anatomy of the face and the skull and the head and all that. Now, generally speaking, when I come to these sort of x-rays, I try and look at the things that the x-ray wasn't meant to be for. So I would try and make sure that I've had a good look at that C-spine. Even though this is a facial x-ray, I would look at the C-spine. But yeah, exactly right. Someone's thrown their you know, opinion in, and you're completely correct. But I'm just going to work through it. So when you're looking at the facial bones, the common thing that we try and think about is that there's this thing like a tripod or like a chair or stool, that as well. So as if little elf is going to sit right over here. And you just want to make sure that everything is continuous. Now, when you're looking at that zygoma, it's going to look like an elephant. I'm going to do my best. I think I'm pretty good at drawing, but you know, when you're doing it on a mouse, it's a bit more difficult. But that's the elephant, right? And you want to make sure that it's completely smooth all the way along. But when you look at the other side, you can't really see the elephant looking so smooth, and you can see that kind of veers off at an odd angle. And it's a bit unusual actually, because usually when you have someone that has a facial injury because they've been punched in the face, which is usually what happens, unfortunately, it's going to be the left side of the face that gets hit, not the right side of the face. So whoever this was probably got hit by someone who's left-handed. But we've got an oblique view. Now, if those of you that want to get to the oblique view, you can click on this mouse over here, this button over here, which is the scrolling button. You can kind of scroll between the two. So I've scrolled to the other one, and this is an OM view, kind of looking at a slightly more angulated view. And look how obvious it is now. You can really see that line there, and it's kind of just completely broken. I've exaggerated, but hopefully you can see that there is a fracture that is sitting there. So that is a zygomatic fracture. But then I just want you guys to know that you're going to want to be looking at everything else on the x-ray, okay? You want to be having a look at that mandible, okay? You don't want to miss the mandible. And also look, can you see that little cheeky peg that's sitting there, right? You don't want to miss those kind of things. I know it's not for that. It's not the reason why I've got the x-ray, but you do want to be looking at the other things. So let's say you've seen the abnormality, look at everything else as well. Make sure you've had your check areas. You've looked at, you know, the things that other people won't see, because that's essentially what radiologists are there for, aren't they? Right, so case number 6, okay? I'm going to get sort of hopefully progressively more difficult as we go on. So, you know, P's x-rays always seem to really throw people off. And I think it's mainly because of the growth plates, right? Pediatric patients always have these little growth plates. And the way to tell a growth plate from something that's abnormal is that a growth plate will have a very corticated edge to it, because it's kind of growing. It's always been there for that patient. It's a normal part of the anatomy. So if we zoom in and if you think to yourself, is this a fracture? You can actually see a slightly more sclerotic as it comes to the edge. So it's clearly not a fracture. But as you come to this posterior aspect of the humerus over here, you can see that there is a line, but it doesn't have that kind of sclerotic edge to it. It doesn't have that sclerotic edge. And I'm going to window it for those of you that are not doing it live with me on the website. But you can see that there is a line like that, and there's a very sharp edge. And a sharp edge is not what you want to see on a pediatric film. And so therefore, this would be in keeping with a supracondylar fracture. And you know, you've got to be thinking about the next thing. What's the next thing, right? The next thing would be the raising of the posterior fat pad. And you can almost see the sort of hypodense radiolucency extending posterior to the elbow. And that is because the fracture has resulted in a joint effusion, which has resulted in pushing out what is normally there, which is a fat pad, into this space here, and now we can see it. And so don't get fooled. You know, if you see a radiolucent line, don't think, oh, that has to be a growth plate. It can be mistaken for a growth plate, but if it doesn't have that very sclerotic edge, it's got a very sharp border to it, you've got to be thinking along the lines of whether this could actually be a fracture instead. And I'm going to try and see if I can just rotate this. It's a very quite powerful little system we've got here for our seminars. And then it can be a little bit more difficult to see on this view over here. So fair enough, you may not see it, but at least you can see the corticated edges of the growth plate. So that's a very well demarcated cortical edge. It's not a sharp line, it's kind of irregularly contoured. So that can't, these bits over here with the radial head can't be a fracture. But what I showed you on the other view is definitely 100% a fracture. So that was case number 6. Okay, we're going to get more and more interesting as we get along. Right, so Taurus fractures, okay, they can, you know, peds don't fracture the way that other people fracture. Like, you know, as we get older, we get sharp definitive lines. Sometimes pediatric patients don't get sharp definitive lines. They get bends, like a piece of grass. Well, you know, when you're bending a twig or something like that, that's exactly what happens to them. And so what you're looking for is actually a bump. You're not, a lot of the time, you're not looking for a fracture line per se, you're looking for a bump, and that would be sort of buckling injury. So this patient's got a sort of buckling injury of their distal radius, and this would be consistent with a green stick fracture. So remember, pediatric patients, yes, I know I did show you pediatric patient with a proper fracture, but they can also have bendy fractures. So young patients can have really bendy looking bones and therefore have bendy fractures. So that's called a green stick fracture. So case number 8, let's go to case number 8. And this is, so look, I know I'm kind of going through more standard stuff, but there'll be some interesting things coming up. So hopefully someone can see it straight away. If you've seen it, great. If you haven't, don't worry, I'm going to go through it. Now, what you find is that most people, you know, not that I'm the kind of person that wants to punch anyone, but if you're going to punch someone, you know, you want to make sure that you got your wrist position correct. Okay. If you're going to punch someone, you want your knuckles to be in line with your wrist. You don't want it to be off the line of it, because if you do that, the force of the punch that you're going to be forcing onto someone's face is going to go in completely the wrong places and end up fracturing specific areas. And genuinely, when I'm doing these x-rays, the first thing I look for with any hand x-ray is that 5th metacarpal, because almost, you know, 80% of the time or something, there's going to be a fracture if that's the method of injury. And normally, you know, what's interesting, people don't actually say, oh, I went to punch someone. They say, I punched the wall. So punching walls is a bad thing if that's what's really happening. Punching people is also a bad thing if that's what's really happening. But you can see that sort of cortical regularity. So I reckon if you didn't look at anything else and you just look at that kind of proximal aspect of the 5th or the base of the 5th metacarpal, you're going to spot a lot of fractures. You're going to spot a lot of fractures because that's a lot of where the fractures happen. You know, some of the findings that will also help you is going to be a bit of soft tissue swelling as well. So just be aware that you can get a few different things here. But if you, let's say you did nothing else on an x-ray of a hand, but check this metacarpal over here, you're going to do okay. You're going to pick up a lot of injuries, because a lot of them are going to happen in that area. Okay, so case number 9. Hopefully it loads up. Right, so these things can be a bit subtle. You know, we're going to have to work through this case a bit. So generally speaking, when you're looking at a foot x-ray, you want to go, you know, if you're going to go, if you look at nothing else, you want to go for the base of the 5th. Base of the 5th metacarpal, metatarsal is going to be where you get most fractures. If you're going to fracture anywhere, it's going to be around there, yeah? If you don't see that, then you're going to have to do the long game. You're going to have to really look for anything else that could be happening. So next thing you want to do is make sure that the 2nd metatarsal lines up with that intercuneiform space over here to make sure that things aren't out of line. Because if they're out of line, then you're probably thinking of something along the lines of a Liz Frank injury. So now, being a radiologist, the next thing I want to be doing is also checking the shafts of the metatarsals. Now, you just make sure that the shafts of the metatarsals are nice and smooth. Now, in this particular situation, maybe someone's seen it. Please feel free to throw your hat in or whatever it is to tell me what you think is going on, but exactly right. There is a stress fracture, and these can be really subtle and so often missed. So often missed. But actually, when you look at that cortex, there's this tiny little fracture there. And sometimes you don't even get that. You get just a bit of haziness, a little bit of fuzziness in the area because it's cortical reaction second to a stress fracture. And interestingly, when you do MRIs of these things light up like an absolute bulb. But when you're looking at plain film X-ray like this, they can be very, very difficult to see. So my top tip for when you're looking at these X-rays of the feet, go for the base of the 5th, go for that line, you know, making sure the 2nd metatarsal is in line with the intercuneiform space, and also then go for that, you know, the neck or the shaft of the 2nd metatarsal, maybe even 3rd, to look for that stress fracture, because stress fractures are so often missed. You wouldn't believe it. You wouldn't believe it. Right. So case number 10. Look, what have we got here? So these spines can be quite difficult, you know, and again, you know, stick to basics, stick to absolute basics, right? So this is a thoracic spine. We're looking at lateral view, and you want to draw a line just to make sure that everything is in line with one another. Now you do have a bit of bonus views of like a bit of the ribs as well. So, you know, you wanted to make sure that you're not seeing a rib fracture. But then I do want to go back to basics on some level, is also just have a look at the shape of the vertebra. Make sure they're nice and square. You're not getting any calcification posterior or anteriorly as well. But as you kind of work your way through, end plate doesn't look so hot there. End plate, where does the rest of the end plate go, right? And then end plate, then end plate, and then end plate. So these are fractures of the end plates. This patient's had a fall and they've had quite a big injury where they've ended up having a lot of force going down through the spine, resulting in fractures in these regions here. You can see there's complete malalignment of the superior end plates of these particular vertebrae. So it's quite important just to kind of go back to basics and make sure that you've had a good look at the normal cortex of the vertebra to make sure you haven't missed a fracture. And these things can be missed. Now, look, I've done a lot of trauma over the years. I actually worked at a trauma center. And what usually happens is that when people fall, they'll fracture in the lower thoracic spine, not the upper thoracic spine. You'd be looking at T12L1 because of the way people fold in on themselves. If you were to try and bend your body, you'd find yourself bending around T12L1. That's usually when you get fractures. They're quite unusual. People kind of just glance and not really look properly. And that can be, you know, that can be detriment to someone like this who actually does have a thoracic spine injury over here. Good, well done. I think everyone's doing really well. Okay, so case 11. So C-spines, genuinely, I think people get really, really stressed about C-spines. So again, if you see it, you go for it. You tell me what you think is going on. Don't worry if you haven't seen it, no worries at all. So C2 vertebra. So the C2 vertebra is this big guy here, okay? Normally it's gonna be sitting around here. Then you got your C3, C4, C5, C6, C7. You wanna make sure that everything is nicely in line. Everything is nicely in line, right? That's one of the things you wanna make sure of, right? And also you wanna look at the soft tissues. The soft tissue anterior to the spine should be kind of close up, but there shouldn't be any bulging of soft tissue, right? But this feels a bit bulgy. It kind of comes out a bit. It doesn't look quite normal. Then you also want to make sure you've had a good look at the spinous processes, make sure there's no, you know, spinous process fracture. Now, believe it or not, I actually saw a case of someone who's doing squats and they had such a big weight on their bar that actually fractured through the spinous process over there. So, you know, for those of you that do like doing a bit of exercise, try not to do, you know, don't do bro weights. You're trying to show off to everyone. But exactly, people have got it. People have seen the absence of a C2 vertebra. There's no vertebra there. Unbelievably, these things can be missed. You know, these things can be missed because you're so used to seeing things, you almost kind of paint it in your mind's eye that this should be there. Why is it not there? And you pretend it isn't there. But there are ancillary findings or other findings that will help you try and see that there's something not quite right here. And it really is that soft tissue sort of swelling that's anterior to the C2 vertebra there that should kind of get alarm bells ringing that the C2 vertebra doesn't look quite right. What on earth is going on? Now, you can look at this view and you won't be able to see the abnormality on this view, but I just want to show you how you would go about trying to look at the AP view, because often people actually ignore it. The main thing you really want to get is just to make sure that I've drawn so badly there. You want to draw a line going right down the center, make sure those spinous processes are aligned with one another. On the off chance, you may see that one of them are out of line with one another, and that can be because of dislocation. It can be because of a unilaterally perched facet joint on that kind of thing. Those are things to think about as well. So just be aware that this is a very important view. In fact, I remember someone actually told me this is a completely useful view, Imran. It's only good for looking at the lung apices. I tend to disagree because over the years, I have spotted a good few completely malaligned spinous processes in these situations, and ended up picking up something quite abnormal later on down the line. So I still think it's worth looking at. Every view that you got is worth looking at, but I think people do ignore it. So this is a bit of a fun one. I like this one a lot, okay? So you guys tell me what you think is going on. Please feel free. I'm gonna give a clue, a bit of a riddle for people that don't know. This patient was one of twins, and one twin was losing hair and the other one had stomach pain. So hopefully that gives it away. So abdominal pain, essentially what's going on. So feel free to write down what you think. If you don't know, no worries, no problems. I'm going to work through it. So we're looking at bowel gas patterns. and you're going to be looking at the bowel gas. Okay, so let's go back to basics, right? Back to basics. We're looking at the bowel, right? We're not looking at chest X-ray, we're not looking for pneumothoraces and that kind of thing. But if you look at the bowel sitting in this region over here, you can see that this looks like small bowel. Why is it small bowel? Because we've got valvular conniventes. Valvular conniventes are lines that go right across, all the way across, right? So when it's as big as that, you know, you're thinking there's something up, something's causing some problems, and you can see that there is some soft tissue density that is sitting over here. Now, can you see over here? There's a soft tissue density stuff that's also sitting over here, but it's also looking the same as the stomach contours. Yeah, exactly right. Some people have said it. Yeah, one twin was eating the other twin's hair. And that ended up resulting in them having stomach pain and therefore resulting in having the situation where they've had small bowel obstruction. Exactly right. So if you look at the CT, hopefully you guys can see it, but if you kind of scroll through, you can see this follow-up CT scan of this patient was this big, big hairball. They've been doing this for quite a while and ended up having this massive hairball sitting inside their stomach, resulting in bowel obstruction. Now, the thing is, this is a weird and wonderful case, but if you go back to basics, if you saw nothing else, back to basics would be the small bowel obstruction. Back to basics would be the soft tissue density sitting in what is normally the contours of the stomach. Not often that you see a soft tissue density sitting in the stomach. Yes, this is the shape of the stomach, but normally it's full of air. You know, it's not going to look like that. So even if you went back to basics, you know there's something up. You're going to end up getting the right study for the patient in the long term. Right, case number 13. Well done for everyone who got that. People do really get a bit, you know, it's a difficult one. So again, we're looking at this particular X-ray, and this is a very, very difficult case. Don't worry if you don't get it. Again, let's go back to basics. Bowel pattern. I don't see any evidence of any dilated bowel. This is all kind of normalish looking bowel, a bit of fecal material within it. We're going to have to go and really start hunting for the abnormality. You may have seen this thing, calcification over here. Don't worry too much when you've got calcifications like that. That is more likely to be a phlebolith rather than anything else. Now we're going to have to actually really do our work. We're going to have to really work at this. Let's have a start look at the spine. Let's have a look at the spine. So the way I was taught is to try and pretend that the spine looks like a little owl with a little beak. So owl, eye, beak, eye, beak, right? And so these eyes are the pedicles and the posterior aspects are the spinous process. And so as you kind of work your way through eye, beak, 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 it all actually looks okay. And you've also got your transverse process as well. You want to make sure there's no fractures or anything like that over there as well. Still coming up short. So has anyone got it? Has anyone got it? No worries if you haven't. This is a tough one. I told you. I wonder if we've got any heroes. So you want to have a look and just make sure that all the sacral bones, all of these all look okay. They all look okay. The pelvic brim looks okay as well. You haven't seen anything grossly abnormal within the region of the sacrum. But actually, when you look at this region over here, it's all about trabeculation when you're looking at the bones. It's subtle, but now when you zoom in, right, you can see that that bit of bone over here doesn't look quite right. That doesn't look quite right. If you look at the bones over here, you can see trabecular pattern. You can see these nice diagonal lines going like this, and it starts to get a bit mottled over here. And some people have got it. Well done. You know, there is a destructive process that is going on over here. Unfortunately missed. They came in with abdominal pain. There's more to the story than that, but there was a big, big whopping destructive bone lesion sitting within the region of the pubic symphysis. So another one that you want to be careful of. So yes, you do start with what the scan or X-ray was for, but you want to be looking at everything else and looking at everything else. Right. So this X-ray is of a young child. I'm not going to say too much more. You can tell they're pretty young because you can see the epiphysis or the growth plate sitting over here. Little clue, there's something a bit abnormal about this one. What could it be? Now, young kids, right? You know, when you're young, your tendons are actually stronger than your bones. Exactly. So your tendons are stronger than your bones. So when you get, you know, when there's someone particularly active, you know, like my daughter's always running around, you know, I can't keep up with her. You know, when you've got these kind of forces going through the bones, sometimes they can cause avulsions. And someone's already said it, someone's already seen it. If you haven't seen it, don't worry. I'm going to work through it. Now, the thing is, the main places where you can get avulsions, the anterior inferior iliac spine, the anterior superior iliac spine, those are the places you can get avulsions. The next place would be the ischial tuberosities, and exactly right, well done. If you look at the ischial tuberosities, there is a stark difference between the two because it has been an avulsion. And what's caused the avulsion? It's the hamstring muscles. This person's probably playing football, doing too much exercise. Yep, exactly. So you've got this avulsion over here. The anterior inferior iliac superior, anterior inferior iliac spine is not avulsed. You don't see any sort of avulsion over here. These are all normal. There's no avulsion of anything over here. The avulsion is sitting over here. Can you see that? That sort of plate-like thing that's been pulled off the ischial spine, has been pulled off, and that's the abnormality there. So this is something that can happen to very young people. And so just something to be aware of. Look at those kind of normal areas, you know, very high yield areas, anterior, inferior iliac spine, anterior, superior iliac spine, and then look at the ischial tuberosity as well. So well done. A few people did get this. This can be a bit challenging. So feel free, if you have seen it, to write down what you think. For those of you that haven't seen it, don't worry, we're going to go through it using a system. So what did I say to do? So we said we're going to be looking at that shaft of the metatarsal, and the metatarsal looks okay. There's not very much in the way of any sort of periosteal reaction. Everything looks very nicely aligned. So someone's thrown in a bit of a Lisfranc, but actually look, it is aligned. It is actually aligned with one another, maybe slightly obliquely seen, but you can see a radiolucent line going between this here and this here as well. So we haven't seen anything grossly abnormal. So we've got our work stuck in, you know, we're going to have to do a bit of work here. We have to work for our money. So now let's look. Base of fifth, that looks okay as well. All right, so no fractures there. Navicular looks okay. Haven't seen anything grossly abnormal. And that's when you've got to start looking. Yeah, exactly right. Can be a bit subtle for people, but there you go. Can you see? There is a fracture. Someone stamped on their toe, haven't they? Someone with high heels, not very happy with them, stamped on their toe, and they've ended up having this fracture of the terminal tuft or the terminal phalanx of the big toe. So quite a nasty injury, actually. You can see there is that line that's going through there like that. So yeah, unfortunate accident to happen to this patient. And, you know, not seen. Some people don't look that far into the terminal phalanges or terminal tufts that often and end up missing these things. So something to be aware of when you're doing it in all practice. But, you know, just use those check areas. So I kind of taken a step back. Hopefully it's a little bit more straightforward on this one. Again, a pediatric x-ray. I just want to illustrate to you guys, these are normal cortices. Like this is normal growth plates because they're kind of getting a bit more sclerotic as you come towards the edge. Yeah, you can see that, right? However, exactly right. Some people are really good on this. You're giving me a run for my money today. So you can see that actually when you look, so trabeculation is one of those things that people don't really appreciate. And I'm going to zoom in and tell you what I mean. So when you zoom in, you can see all these linear bits to the bone. That's trabeculation. That's normal looking bone, right? So you want to see that. You want to assess that when you're looking at x-rays. And actually, when you look at this x-ray, you can see that there's a slightly abnormal texture, like an abnormal texture to that bone. It kind of looks slightly more hyperdense in this particular area over here. It doesn't quite look the same as like the cortex over here. The cortex over here looks a bit more hyperdense. You'd almost try and draw your line around there. You can't say it's a well-defined line. If you see a well-defined line, like as if I've got a pen, like I've just done now, I'll draw a pen. If I could draw it and say, look, that's where the lesion, there's something abnormal there, I could draw it, then you're probably looking at a completely different differential. But because it's ill-defined, it looks a bit hazy. Hopefully you guys can agree with me. It looks a bit zigzaggy, a bit hazy, all the way up to this area here. You've got to start thinking about aggressive versus non-aggressive lesions in a young patient. Now, I know people go, oh, this has to be malignancy. It has to be it doesn't have to be malignancy. It can be a malignancy, but all you can really say from plain film is that this is an aggressive lesion. That's all you can really say. Differentials could be, you know, yes, it could be Ewing sarcoma. It could be all those things, but also because it comes all the way to the growth plate and doesn't go any further, you start to wonder where this could be infection. It could be a Brody's abscess. This patient could exactly right. Well done. They could have osteomyelitis, and that could be, you know, when someone's kind of going through their reporting pile, they don't see it. If you're trying to appreciate the trabecular patterns, at least for a lot of the plain films, you'll pick up so much in terms of fractures, in terms of lesions, all sorts of stuff. Now, because we're on the PEDS X-ray, I'm trying to give you everything that I can. I want to point out that sometimes people get worried. Is this like, has this, you know, this part fallen away from this part? Is there like an avulsion injury, or, you know, is there some displacement of slipped epiphyses? What I want you to do whenever you're worried about that is draw a line going all the way down and make sure it's lined. Now, that rule doesn't quite work for the majority of the time, because actually you want to be the worst artist that you can be, right? You want to draw a bad line, not a good line. You want to draw a bad line. So you want to do this, but then kind of bump out a bit and then come along. If you can kind of bump out a bit and then come back into where you are, then you're probably not looking at any sort of displacement or fracture. Because you have to remember there's like this chondral material that's sitting over here. It slightly bulges out. And so you're going to get a little bit of lipping of that cortex as it comes towards here, and a little bit of lipping of the cortex over here. So you've got to try and almost cater for that lipping of that cortex as it comes up to the growth plate. And that doesn't disappear until that growth plate goes away. So don't start worrying about that kind of stuff when, you know, kind of a fracture. Okay, so this one, oh wow, yeah, well done. Maybe, are you going ahead of me when you're doing these ones? That's fine, good, well done, well done. Maybe you got bored of the last one, went to the next case. So exactly right, you want to be looking at the, you want to go back to basics, right? So one of the things I'd be looking for is that fibular head. Often, you know, fractures in the fibular head can be missed. You might see a little fleck of bone sitting around here. That would be a Sagon's fracture, which would be indicative of an ACL injury, right? So need to go for further imaging. But again, with any sort of fracture, you just want to make sure you're drawn along the cortex, and you can almost see that there is an irregularity to the cortex on that side. And on that side, it's smooth, that's all smooth, that's all smooth, and that's all smooth. There's an irregularity over here. So you're thinking, yeah, tibial plateau fracture. If you do that zoom, the scrolling function, you'll be able to get to the next image, which is the horizontal beam image. And you can see that there's this horizontal line indicative of, you know, there's lipohemoarthrosis. So there's blood that's sitting here, which is dense, is sitting down here. You've got all the fat that's sitting up here. You get this nice little layering, not nice for the patient, but nice for us to see that if you see that and nothing else, you're looking at a fracture. There's a fracture somewhere in this and needs to go for further imaging. But on the AP view, we did see a fracture. So well done for those of you that picked it up. Well done. So you don't have many more. Thank you so much for sticking with me. I'm trying to give you as much value as I can in the little time that I have with you. Right, so again, feel free to throw it in there. Throw in what you think is going on with this patient. Exactly, well done, well done. But listen, again, back to basics. Look for trabecular, look at the cortex, right? Look at the cortex. As you go through the cortex, you might see a little bit of zigzag, right? If you haven't seen that, look at the trabecular pattern. So when you're looking at the calcaneum should look like a fan, yeah? It shouldn't have any disturbances, but this has a sort of cortical disturbance over here. So if you didn't have that little break in the cortex, right, you may only see like a line like this, which is abnormal because you'd have like a fan-like appearance to the calcaneum, not a line that goes against the grain. That case, you may have a stress fracture. In this case, you have a proper fracture because you actually have a zigzag line sitting over here. If you weren't still sure, but look at the size of that heel pad. Look at that. There's so much edema over here. So there's clearly something going on in this region. That may help you draw your eyes towards this region, which may help you draw your eyes towards this. There is a calcaneal fracture. Well done. Yep, that is a calcaneal fracture that you'll be seeing over here. Good. Oh, case 19 didn't work. No worries. Let's go to case number 20. Case number 20. You know what? I'm gonna let you stew for about a minute. 1 minute. I want to help you. I've left this one till last because I want you guys to sort of hopefully be challenged with some of the cases, because you guys, some of you lot have been absolutely obliterating my cases. So let's go. 1 minute. 1 minute. I want you to have a good scoot through, see what you think. And for those of you that aren't logged in, don't worry. I'm going to try and do my best to sort of make it a bit fun, kind of just go through. Oh, someone's seen the red dot. Well done. Well done. So there's clearly something not quite normal. We're going around, we're having a look. I'm kind of pointing you towards there, pointing you to over there. Yeah, people throwing in lytic lesions. Yeah, we're having a look around here, looking around here. Well done, keep going. A few answers, someone saying normal, not bad shout. I'm telling you they're in a lot of pain. So I'm gonna say, look, mate, I'm not gonna give you a normal one at the last one. So try and give me something, come on. Not long, 15 seconds to go. People are coming out with it. Good, well done. Yeah, should have gotten with you something more challenging than these. Okay, good. So 7 seconds to go. People are really throwing it. Good, well done. 4, 3, 2, 1. You lot, honestly, well done. Okay, so for those of you that didn't see it, this is a challenge. What you need to do is, again, follow the lines, right? So you want to follow all the lines round. So if you didn't see it, go back to basics, look here, anterior, inferior, iliac spine, anterior, superior, iliac spine, no fractures, trabecular pattern looks okay, femurs look okay, inferior, superior, you know, to make sure they're all okay, pelvic brims all good as well. But often people don't see this, and some of you did, which is really, really great, really, really encouraging. I think we've got a really good cohort today. You draw a line like this, and you want to draw a line all the way along like so, all the way along like so, all the way along like so. And can you see that? This kind of goes zigzag there, zigzag there. Can you see that? Abnormal. And then actually, as you start to look, you start to see a few more zigzaggy lines that you shouldn't really see. So exactly right. There's a fracture of that left sacral alar sitting over there. So quite a significant injury that can unfortunately be missed if you're not looking close enough. So my big take-home points, hopefully, please explain the SCFE. Okay, so look, SCFE, do you mind just not abbreviating that? And maybe because I'm stressed in the situation of presenting, I'm not sure what you mean. But slipped, all right, so listen, you know, on this one, you're not going to get slipped femoral epiphyses, right? The reason you're not going to get slipped femoral upper epiphyses is because you don't have growth plates. You need a growth plate to have a slip. So you wouldn't see that because you can't see a growth plate sitting there, yeah? If you were going to see a slipped femoral epiphyses, you'd have a growth plate sitting there and you'd actually see this sort of the femoral head sort of falling out of place, completely out of line. And what you want to do is sort of really draw a line, you know, draw a line. And remember how I said draw a bad line? You still want to draw a bad line, right? You want to draw a bad line around the epiphysis, just make sure that everything is nicely aligned. You won't be getting that situation here because when it's fused, you can't slip anything. You just can't slip anything. It's not possible with this patient here. But that, you know, on the actual course, I'll be going through that more closely. But this is, you won't see that here, but you'll be looking for a malalignment, a quite distinct malalignment. Good. So those are all the cases that I have. Well done. Thank you so much for listening in. I hope that was useful and I've given you guys a bit of a way to go through some basic x-rays. There's no way switching on the camera, is there? I still got that silly picture of me that someone tweeted at me the other day, and I thought it was quite funny. They were saying that the little animal was asking for a scan, and I edited to be like, you know, look, if you're going to make a radiologist, you're going to have to give them a crown and some sunglasses, otherwise they're not a real radiologist. Anyway, thank you so much, everyone, for signing in. Feel free to ask any questions. More than happy to try and answer as many as possible. For those of you that are into social media, please feel free to follow us on social media. I'm on Doc Lasker on Twitter and YouTube and all the rest of it. I do have a bit of a giggle, so you know, please feel free to give me a bit of a hard time as well. It's always good fun to be on the receiving end, a bit of fun as well. So thank you so much, and I'm going to hand over to my colleague, Dr. Saeed, who's just going to bring us home. Thank you.
So thanks so much. And for those of you who watched it live, you'll get a 1 CPD point. Simply go on to this website, webinar, feedback.radiologyseminars.co.uk. If you've got a phone handy, just take a picture of the QR code. It'll take you straight to the feedback form. We've got a couple of, and I think this kind of bite-sized learning in the evening, keeping it short and snappy, people really, really do find it helpful. And I think we've got an excellent turnout in that, and that's really good to see. And as the feedback that you guys give is what sort of motivates us to keep doing these. We've got a full day of emergency X-ray course happening in April, 10th of April, it's a Saturday. So that will be going through the sort of the entire gamut of sort of head, neck, facial, spine, upper limb, lower limb, etc. So that's more for trauma. And then we've got a chest radiograph reporting course that's done by one of the cardiothoracic radiologists, who's also the training lead for chest imaging. I mean, lots of other things. Check out our website, radiologyseminars.co.uk. But otherwise, if you, for the CPD point, please do give us feedback. It's really helpful. The webinar next month, I've forgotten to put on here, is on abdominal x-rays. It'll be approximately this time next month, so you know, nearly 4 weeks away. There will be recording available. We will email you the recording probably early next week. So probably Monday, Tuesday, we'll send an email out. If you've signed in already, you'll get an email with the recording link. And for those who haven't been able to forward the link to your friends and colleagues who want to watch the recording, and we will post this recording eventually on the website as well with the other webinars. Hope you found it useful. If you have any questions, we can take some questions now. Otherwise, we will log out. I don't think there seem to be any questions. That's good. My mouse has suddenly disappeared. Right. If there's any questions here, here we go. Let's have a look. Fine. Excellent. So, and those cases are available for you guys to have a go at as well. So those who are going to be watching this later on, do log on to that link we've sent you. Excellent. Thank you very much. Have a nice evening. Bye-bye.